Good afternoon. Magandang hapon sa inyong lahat. My name is Dr. Yarcia from NoBox Philippines, and together with Dr. Elmer Soriano from Civica Asian Development Academy, we welcome you to this session entitled Heart, Intent, and Velocity, Pioneering Sensible Harm Reduction Responses in Malaysia. We are very honored to have a distinguished and well-respected expert today with us on harm reduction. Dr. Adeeba Kamarulzaman is the president of the International AIDS Society, the world's largest association of HIV professionals, comprising more than 12,000 members across 170 countries. Dr. Adeeba is also the chairperson of the Malaysian AIDS Foundation, and she is highly regarded as the leading clinical expert for HIV and AIDS in Malaysia, and is known to be the driving force and one of the architects of Malaysia's successful harm reduction policy for people who use drugs. Dr. Adeeba is considered to be one of the key proponents in reforming drug policies, espousing a public health approach that decriminalizes drug use and promotes diversion to community-run services. Dr. Adeeba will be sharing her pioneering work on harm reduction in our neighbor, Malaysia. And without further ado, I'd like to give the floor to Dr. Adeeba. Thank you very much, Dr. Adeeba, for being with us today.
It's a pleasure, Dr. Lee, and thank you very much to NoBox for inviting me to share what is it now, but a 15-year journey of implementing harm reduction in Malaysia, and then a few years before. And the journey continues, I think. So it is my pleasure to share with you the 15 years of work, not just by me, obviously, but all my colleagues who've been working very hard to implement both needle syringe program as well as the opioid agonist treatment or methadone maintenance treatment in Malaysia. So if I just can very briefly summarize, as many of you know, we here in Asia tend to favor a much more punitive response to substance use, and Malaysia is no different. We have 4 different sets of laws, the Dangerous Drugs Act 1952, that includes the mandatory death penalty for drugs as listed there, judicial and corporal punishment for possession of drugs, and incarceration. We also have the Drug Dependence and Treatment and Rehabilitation Act 1983 that calls for compulsory rehabilitation and supervision orders and random urine testing. And then we have the Poisons Act, which includes fines for possession of drugs not categorized by the DDA 1952. And finally, a more recent Dangerous Drugs Special Preventive Measures Act 1985, which allow for detention without trial for people suspected of committing a drug offense. So as you can see, in short, we have numerous laws that penalize people who use drugs for personal use, as well as, of course, for trafficking. And over the years, I think there's been a recognition, just as there has been in most parts of the world, of the failure of this approach, of failure of the war on drugs, globally as well as in Malaysia, and how the dominance of law enforcement over health and the moral and religious framework linked to prohibition and abstinence have created more problems than what it I guess when these laws were established those many decades ago with all good intentions. And so we have a very sizable problem. This is a little old, but as of 2018, as you can see, the total number of people who've, or the section 39B for trafficking, 6,684 people were charged. 39C is mandatory death sentence. 39A for major possession, and on it goes. So for 2018 alone, close to 160,000 people were charged for various, imposition of the drug laws. And it's no surprising then that we have an issue of overcrowding in prisons that have been known for many years, but of course, in the setting of the COVID-19 pandemic has created many clusters of infections, not just amongst the incarcerated individuals, but also amongst staff and their family that, created another problem for us here in Malaysia. So with those years of a war in drugs and a punitive approach to drug use, harm reduction was resoundingly rejected back in the late 1990s, or early for the whole 1990s, as the HIV epidemic was escalating, and so that there was opposition to the introduction of substitution treatment and opposition to introduction of needle syringe program. And as we watch the number of people becoming infected with HIV continue to climb, so much so that we earn the rather unpleasant title of having a mega epidemic of HIV in this publication in the Lancet, together with Vietnam, Ukraine, China, and Russia. At one point, in the early 2000s, we were seeing an annual new cases of HIV, anywhere between 3,000 to 6,000 new cases, new diagnoses of HIV reported annually between the 1998 and 2005 or so, when we introduced harm reduction. So along with HIV, the overcrowded prisons were also a good setting for TB infections. And in this study that we did in Kajang prison, where we've had a program for more than 10 years, a terribly high prevalence of latent TB was found in both prisons that we did the study in, up to 88% and 87% respectively, not only amongst prisoners but also amongst the staff in Kajang prison, the largest prison in Malaysia. So just some figures on overcrowding, and our prison system has an official capacity of about 40,000, 45,000, and we're now at about 50 to 60,000 at any one time. And of those who are in prison, 56% are due to non-violent and minor drug offences. So this was a statement from the Deputy Director General of Prison at the time, that some 35,000 prisoners are in prison because of drug use. So with all that happening, so in around 2003, when we were seeing increasing number of people becoming positive for HIV due to injecting drug use, a group of us formed a working group on harm reduction. And I can still recall, I had a small grant from the NIH US to do a desk report on a situation analysis of HIV and drug use, and we used that to kind of advocate. We had a meeting that brought together people working in HIV and people working to support people who use drugs, and some academics, and a colleague of mine, Professor Nick Crofts from Australia, and discussed the situation at the time. This was in 2004, I think. And we then decided to form a small working group of like-minded people. I think there were only about 10 of us at the time, and did very targeted advocacy to the National Drugs Agency, to the police, to prisons department. And it became clear that, you know, unless there was a policy change and unless we went to the leadership, things were not going to move. Because when you talk to the police, they will say, oh, well, you know, that's what the law say. When you talk to Ministry of Health, they say, you know, what can we do? We're not allowed to give clean syringes. And you talk to prisons, they say, yeah, you know, the prisons are overcrowded. So with that, at the time, I was the president of the Malaysian AIDS Council, and through the assistance of Marina Mahade, who was also still on the council at the time, we managed to get the attention of the political leadership. Fortunately or fortunately at the time, I think we also had to report back to the midterm review of the Millennium Development Goal and of the, you know, the precursor to the SDGs. So of the MDGs that you know, we had to achieve, the only one that we didn't achieve was to reverse the HIV and TB epidemic. So I guess you can say we came at the right time and got the political leadership's attention. And with that, we were given the green light to pilot initially the methadone maintenance treatment, and then eventually 6 months later, the needle syringe program. We piloted the needle syringe program at three sites, funded by the government and working hand in hand with colleagues in the Malaysian AIDS Council, who oversaw the programs at three different partner organizations. So, you know, there was a lot of work trying to find partner organizations who would be willing to take on the needle syringe program, because for many years, many of these partner organizations were working within a abstinence framework, and to them this was quite foreign to you know, to be delivering clean needles and syringes. The methadone maintenance treatment was taken up by Ministry of Health, and you know, guidelines were put in place, training of doctors and general practitioners, and with that, you know, we slowly scaled up, as you can see here, the timelines of harm reduction. Essentially, the methadone maintenance treatment was delivered through the Ministry of Health and general practitioners, and the needle syringe program through the partner organizations under the umbrella of the Malaysian AIDS Council. All of these programs were mostly funded by domestic funding, except for a small portion from Alliance, and then eventually we proposed the Global Fund and received some amount of Global Fund funding for the needle syringe program. But by and large, the majority of the program has been funded by domestic funding. So one of the first few steps that we had to do was to form a national task force on harm reduction. It consisted of interministerial task force, NGOs, the religious body, and academics. So I've mentioned about funding, and the component of the harm reduction program was opioid substitution therapy, needle syringe program, as well as other psychosocial support that's so essential for recovery. So the methadone maintenance treatment commenced in October 2005. To date, we have many centers delivering opioid substitution therapy. At one time, the prisons were very active as well, but as well as the drugs agency were very active. But since 2011 or so, that the drugs agency have had new leadership who were not so much in support of the harm reduction approach, and hence the importance of for me, I think the importance of a total overhaul of the drug policy is needed, because we keep seeing, with the change in leadership, there will be or there will not be support for programs like needle syringe program and a much more public health-based approach to drug use. So this is the coverage of harm reduction, of methadone. And as you can see, back in 2006, HIV prevalence was 21% amongst people receiving methadone in government clinics. In 2017, it's gone down to 3.39%. Likewise with Hep C. With needle syringes, as mentioned, by and large, the program have been delivered by our NGOs, the partner NGOs. But in recent years, we have tried to incorporate this distribution of clean needles and syringes through the government's own health centers. In Malaysia, it has a very widespread system of district and district clinics and even small local clinics. And so we've incorporated delivery of these clean needles and syringes through these clinics to save costs and truly integrate prevention especially in rural settings. So this is a measure of acceptance over the years towards this program within the Ministry of Health itself. And as can be seen, as part of the National Strategic Plan to End AIDS 2016 to 2030, strategy number 2 is prevention of HIV transmission through injecting drug use, and both expansion of opioid substitution therapy as well as needle syringe program are key measures within the National Strategic Plan to End AIDS. So, as mentioned, after years of introduction of this program, I think it's safe to say that harm reduction is now quite well accepted within the Ministry of Health of Malaysia. And we have seen a tremendous success. Obviously, that's not the only reason, I guess. There's been a change, also a trend, as has been seen in many parts of our region, of the preferred drug use from heroin to amphetamine type substances. And I think the mode of HIV transmission has very much changed towards sexual transmission. I dare say quite a bit of it is still fueled by drug use, particularly recreational drugs like ice and other stimulants. So, which presents a different set of headache and challenge for us all. But for opioid using individuals who have access to the harm reduction program, I think this clearly demonstrates the success of the program. Like I said, in the past, we would see up to 5,000 new HIV diagnoses as a result of injecting needles, but now that's really down to about a few hundred cases a year, or approximately 3% of the annual new infections are due to intravenous drug use, as opposed to 61% in 1990, 48% in 2010. It's now down to 3%, and the majority of infections now are from MSM and also heterosexual transmission. So this is another graph depicting the sharp decline in number of new cases from drug use compared to sharp increase from sexual transmission. One of the things that we have used as well to advocate for the continuation of harm reduction is, of course, It's not just in terms of the public health success, but also in terms of the economics. And here you can see that imprisonment leads to an annual cost of 20,000 ringgit per year per prisoner. This is in compulsory detention centers, which are even more costly. And the price of methadone in public and private, and buprenorphine, which is slightly more expensive, are all good reasons why expansion of treatment is so much more preferable than the criminal justice system. So this is sort of the if you look at this is work from my colleague Dr. Bigna from University of Science Malaysia. This is if you multiply it by the number of prisoners, like I shared with you earlier, and the annual cost is just huge. We also did an evaluation of the harm reduction program after 8 years of the program. This was done in 2013. So we looked at, we modeled, did a modeling study of with colleagues from University of New South Wales. With harm reduction, how many new infections would we have had? And the answer was between 2006 and 2013, we would have had 20,000 new infections, and by introducing harm reduction, if we had not had harm reduction, we would have 14,000 more new infections in those 7 years. And so we believe that the reduction in number of new infections in the first few years of introducing the harm reduction program was as high as 40%, and if you project it up, it would be as high as 87% and 79% respectively. And this is even without expanding the coverage of both those programs. And when you put that in terms of dollars and cents, it's a cost saving of 47 million ringgit for those 7 years, 209 million ringgit for the extra 10 years. And if we project it to 2050, the cost savings is close to 1 billion ringgit. Whenever I give this presentation, particularly in Malaysia, I always joke that if I was the CEO of a company and we did something like this and saved the company 900 million ringgit in 40 years, or even 47 million ringgit in 7 years, we would all get a big bonus. But alas, we got a thank you and a pat on the back, I guess. In addition to the Ministry of Health programs for methadone and needle syringe program, back in 2010, a very progressive Director General of the Anti-Narcotics Agency, which has been charged with looking after prevention and treatment for people who use drugs, came on board and embraced harm reduction, if you like, and started reforming the compulsory rehabilitation centers, and instead of a punitive, mandatory, institutionalized period of rehabilitation, she and Dr. Sangeet Kaur, my very good friend and colleague, Dr. Sangeet Kaur, went about transforming this compulsory detention centers into open access ambulatory voluntary centers that were called Cure and Care clinics, and cure and care rehabilitations all over the country. And they provided not just treatment and health education, but also psychosocial support, including relapse prevention, family programs, counseling, religious instructions, etc., etc. And when we reviewed this program in an interview, 56 of them said it helped maintain employment. 54% said that it helped them to go back to their education, improve family relations, prevented arrest. We also did a prospective study comparing those who were receiving methadone through this community services, whether versus those who remain in compulsory detention centers. And as this Kaplan-Meier shows, a stark difference in terms of median time to relapse to opioid use after release from these compulsory detention centers, otherwise known as PUSPAN. The median time to release was 31 days, as opposed to in people who were in the voluntary community-based centers and receiving opioid. There was half of them were still not using drugs, and of those who relapsed, it took at least out to a year, as opposed to just within a month of release. And we concluded that those attending the community-based voluntary centers had an 81% decreased chance of opioid relapse compared to the mandatory detention centers. And this was published in Lancet Global Health. Despite all this, the opposition to taking a more health-based approach, voluntary treatment and support remains very, very difficult, and there continues to be a dominance of law enforcement over health and a moral religious framework linked to prohibition, of course, the issue of corruption as well. And so other than our ongoing effort to see a drug policy reform towards a more social and health-based approach, of course, we're also faced with the challenge of, as mentioned earlier, the changing trend in drug use to polydrug use and amphetamine-type substances, which present a completely different challenge in terms of harm reduction. I think, unfortunately, we're still searching for the methadone or buprenorphine equivalent for ATS types, amphetamine type substances. The best we have at the moment is cognitive behavioral therapy. And so there's no easy answer. Of course, for those who are injecting, and there's a proportion now who are transitioning from smoking to injecting the same principal supply in terms of clean needles and syringes. The issue with ATS users is they don't identify themselves necessarily like other drug users, and will not necessarily access traditional harm reduction services that's being used by opioid users. So as mentioned, the other challenge is, of course, punitive drug policy essentially remains unchanged, although in recent years, I'd like to think it's through our ongoing effort to advocate to various stakeholders. We've had signals of in the previous government, as well as the current government, that are more open to discussions around a more health-based approach to drug policy. And finally, of course, as if all that was not enough, the disruption from the COVID-19 pandemic to the services, to harm reduction services, has not been insignificant. And so just a quick one on how do we introduce harm reduction approach for methamphetamine users. This is a publication from Jakarta. I think the same, in a way, the same principles apply: building trusting relationship with our stakeholders on both ways, adapting safer smoking kits to local circumstances, reframing partnerships, and also address underlying mental health issues. and finally working together with law enforcement. And so, in short, I think at least the harm reduction, the traditional harm reduction services, i.e. needle syringe program and opioid agonist therapy, have proven to be successful in Malaysia from the point of view of preventing HIV transmission, and to a lesser extent Hep C transmission. But I think overall, in terms of if we truly want to provide a supportive environment for people who use drugs, then nothing short of a total revamp of our drug policy is required. And it's something that my colleagues and I, including Dr. Sangeet and many others, are working on. And there is a silver lining in the COVID-19 pandemic. The outbreaks and the clusters in prison have opened an opportunity for us to advocate even louder and stronger for a drug policy reform and a prison reform. And as we say, alhamdulillah, we've had some traction. We've been noticed by some very supportive parliamentarians, and last year or late last year, an all-party parliamentarian action group to address prison overcrowding was formed, and to provide high-level discussion and advocacy to take this work forward. So obviously you can't address prison overcrowding without addressing drug policy reform, and so we have much work ahead of us to address all these issues. And so, like I said, this is from the previous law minister. Unfortunately, he passed away. He was very supportive of a social approach, social and health approach to drug use. And there's a quote here of him saying that. As I said, even with this new administration or this current administration, I believe some of this work will be continued forward. So with that, I thank you very much for inviting me to share our experience and journey for more than a decade on harm reduction. And as we continue to not only ensure that the work on harm reduction continues for people who use heroin, but also to, much work needs to be done to employ the same principles for a newer challenge of ATS users, and in amongst all that, continue to advocate at the highest levels for changes to drug policy and obviously to prison reform, because without changes to our laws that I shared with you at the very beginning, then I believe we're just firefighting with the harm reduction measures, albeit successfully in terms of preventing HIV transmission. But I think in the total well-being of people who use drugs, in ensuring their dignity, in preventing that sort of relentless vicious cycle of cycling in and out of prison, we just need to keep going hard as it is with seeing some form of drug policy reform taking place in Malaysia and the world over. So thank you very much once again.
Thank you very much, Dr. Adeeba. That was a very astonishing presentation, and looking at the impact of harm reduction to HIV, even on employment, education, building and fostering relations. These stories are very inspiring. And looking at it actually in your timeline, it's around 1998 when Malaysia started in the harm reduction initiatives. And I'd say the Philippines right now is around the 1998 Malaysia timeline. And we'd be very interested to continue the discussions on it. Dr. Elmer and I have been involved in academic initiatives on drug policy reform here in the Philippines, and I'd actually like to invite Dr. Elmer to share his thoughts and reactions to Dr. Adeeba's presentation.
Thank you,
Thank you,
Dr.
Lee. Yeah, thank you, Dr. Adeeba. That was an amazing presentation. As I was listening, I couldn't help but think that you were part doctor, part lawyer, part parole officer, part social worker, all rolled into one, no, over the past couple of decades.
I've been a bit busy, yes, thank you, but
Yeah.
it's been worthwhile, I think, yeah.
Right, and so I guess the question is, how would you train the next generation of leaders like yourself, right? So going to med school is not enough, right? The clinical skills are not enough. I mean, how does our generation prepare the next generation of leaders to be able to navigate through all of these complex, interdependent issues and provide leadership? How would
Yeah,
you cultivate
thank
the
you.
next generation of leaders to take
Yeah,
over
thank
you?
you, Elmer. And I think that's a really, really important question. One of the other things that I did up until recently was I was also the dean of the medical school, and which gave me an opportunity actually to make some of those changes that you mentioned. And whether it's drug use or stigma or people living with HIV themselves, drug use, MSM or living with HIV. Stigma is our Achilles heel, isn't it? And I firmly believe that that needs to, and healthcare workers are some of the worst culprits. So what we did was ensure that in our curriculum, we introduce subjects and bring patients into for our students right from year one to be introduced and to get to know people living with HIV and all the other key populations. Of course, when they enter into clinical setting, because we have a large HIV ward. So that's one example, and I guess also cultivating, as you said, the next generation by I've been lucky in that I've had a few people come forward and send them for further training, and hopefully see the new generation of leaders. We actually only 3 weeks ago, I sat down with a group of young doctors and public health students who have formed a small group called Student Leaders in Evidence-Based Drug Policy. So, there is real hope that the next generation will take on our work. Yeah.